Namaskar and good evening to all the viewers, especially Star Foxens. So this is Gyan Pravah series, episode 269, which is the brainchild of our glorious President, Dr. Sunita Tandulwadkar, Madam. She has taken Fogsi to the global level by having so many projects, that is Sampurna, Doti Ke Zindagi Ki, Eagle, Know Your Number, and many more. Madam is Director and Consultant HOD of IVF Endoscopic Center, Ruby Hall Clinic, Pune, Solo Clinic IVF, Co-founder and Medical Director of ELIV, Stem Cell Research and Application Center. She is serving as President Fogsi this year, which is the body of more than 49,000 doctors. And she is President-elect Isha for 24-26, founder President of Society of Ovarian
Kavita, thank you so much. It is today your
Mr. was starting recently. Madam has been awarded FRCOG. Okay, Madam. Recently, Madam has been awarded FRCOG at London, and she has also received the Star Foxen Award by our past President, Dr. Nath Kovind. So, Madam, with no introduction, she has become popular and has become a global leader. So, I wish her the best, and really, I'm honored and obliged for giving me opportunity. So, Madam, okay. So, thank you. I'm honored and obliged to our President, Madam. I think she is very kind by heart, but tough from outside. But Madam is really very kind and generous.
Can you hear me? Can you hear me? Thank you so much, dear. It is not a podcast on me. It is a podcast of you and sir. So, please, enough about me.
Okay, Madam. So today the topic is fistula care and incontinence. We all are aware that women have different types of urogenital fistula and rectovaginal fistula, both due to obstetric and gynec causes. But urogenital fistula is more common than rectovaginal fistula, especially in our part, in developing country like India, and the life becomes hell and patient has trouble. So today we have a very renowned urogynecologist from BP Koirala, Dharan, Dr. Mohan Chandra Rigvi. He is Professor, Department of OBG, BP Koirala Institute, and Senior Consultant, Civil Service Hospital, Kathmandu. He is Program Director of Urogynecology Fellowship Program, Nepal, and this is the first program supported by Foundation International Urogynecological Assistance after their first program in Ghana. So first program was in Ghana and second program held in Nepal. He is Treasurer of International Society of Obstetric Fistula Surgeons, Member Editorial Board, Nepal Journal of Obstetric Gynecology, National Trainer of Obstetric Fistula, NCTC, Ministry of Health and Population, Government of Nepal, Chief Policy Advisor for Reproductive Health, Ministry of Health and Population, Nepal, Vice President, South Asian Federation of Urogynecology, Vice President, Nepal Society of OBG, Eastern Chapter, and Registrar of BP Koirala Institute between 2021. He was HOD in BP KHS and Senate member, BP KHS, Academic Council member, Regional Coordinator, and National Coordinator of Urogynecological Subcommittee through Nepal Society for Obstetric and Gynecology. He is consultant of International Nepal Fellowship, Japago Corporation Nepal, UNFPA Nepal, founder and chair of Fistula Free Nepal. And he has got one website, www.fistulafreenepal.org. He is faculty of ICS educational course in Nepal, Ayuga, resource faculty, All India Congress operative and resource faculty, president of Nepal Medical Association, Dharan branch, and many more positions. And he has got many awards also and training like Pfizer Fellowship Program in Johns Hopkins University, Ayuga Observership Award, and many training fellowship in refresher training of obstetric fistula. So to name any SOC Best Paper Award, SSYGA Young Gynecologist Asia, Ayuga Observership Award 2011, ICS Clinical Fellowship Award, Pfizer International Scholarship Award, Shati Award, Mahila Sanjal Dharan Award, Best Professional OBG, CMO Asia Award, and International Society of Obstetric Fistula Surgeons Award, Mozambique, Maputo in 2022. So I think Dr. Mohan C. Ragni sir has worked a lot in fistula care, and he has trying to make Nepal free from fistula. So I'm really honored to have him as a guest speaker. And Dr. Mohan C. Ragni is also coming to Madam AICOG 2026 in workshop. and we have invited him, and he has accepted. And more than that, my daughter has also passed MBBS from BP Kerala Institute, and this is really very prestigious institute. So, Madam, you want to say something, or we should start the questions?
Dr. Kavita, thank you so much. And Dr. Mohan, it is our honor to have you on a Fogsi platform. This podcast series we are running for last 260 days now, every night at 8 p.m. And I'm so glad that all the chairperson bring out the best of the academic or non-academic background. So maybe a spiritual, philosophical, social worker, politician, anyone. And we always have a good interactive session. So thank you so much for being with us. And we know that we requested you to stop the car so that your connection did not go. Thank you for your time for that. Thank you. I just joined to welcome you all and to give the respect.
Thank you, madam. Thank you so much for your blessings.
Thank you.
Thank you, madam, so much. I think madam's connection is lost. Pradeep?
Kavita, your connection is unstable because me and Dr. Mohan, we are moving and we can see each other moving. Yeah. So I request continue. Thank you.
Thank you, madam, for your blessings. Okay. So Dr. Mohan, you say a few words about you, and then we will start the questions. Okay.
Yeah, thank you, Sunita madam and Kavita madam. It's an honor to be part of this Fogsi initiative. I'm really very privileged to give this deliberation so that it benefits gynecologists. Thank you for this opportunity.
Okay, so you have worked a lot about the fistula. So we just start. We all know what is fistula, but still we want to know what is a fistula, especially urogenital and rectovaginal fistula. We are more concerned about urogenital fistula because this is commoner as compared to rectovaginal fistula. But just you define what is a fistula.
Yes, madam. Fistula, basically focusing on genitourinary fistula, is an abnormal communication between urinary bladder or renal tract to vagina. It could be ureteric fistula, it could be vesicovaginal fistula, or urethrovaginal fistula. We are more concerned, as you said, about genitourinary fistula, but rectovaginal fistula also are common, particularly secondary to neglected for third and fourth degree tear, which are now also increasing in developed country as well as this part of this world. So these collectively, these two terminology are also now defined as pelvic floor fistula. Among pelvic floor fistula, today we are focusing more on genitourinary fistula, which basically more have urinary presentation.
Okay, thank you so much. So really urogenital fistula is more common, and especially in our part where still birth occurs after prolonged labor, obstructive labor, and vesicovaginal fistula is commoner. Ureteric fistula is common after gynecological cases, but vesicovaginal fistula is commoner after obstetric cases, which we find many times. So, what are the symptoms of fistula?
Yes, madam. So, because it's an abnormal communication, normally woman should be able to void when she wishes to void, and when there is no situation that is favorable for voiding, she should be able to hold. So that is the usual thing. So in fistula, she will have abnormal leakage of urine all the time. She will not have any control. So the presentation can be quite variable, like it can be continuous leakage of urine in vesicovaginal fistula, particularly which is mid-vaginal fistula, anterovaginal wall, mid-vaginal fistula will have continuous leakage of urine all the time without control. She will be wet all the time. But if the fistula is uretrovaginal, the leakage could be positional. The woman, when she lie down, there will be no leaking. When she stands and walks, she will have leaking. And in ureteric fistula, woman will have leaking, but also she will be able to void, because either one or two of the ureter might be partially or totally damaged. So the woman, she will leak urine through vagina. So one ureter might be draining in the bladder. So she will have sensation of urination as well. So most of the symptom in general, continuous leakage of urine, which is typically characteristic, and you can always diagnose. Even a paramedical person can diagnose fistula. Usually couple of questions are sufficient. Do you leak urine all the time and you do not have control? One. The second is whether it is started after childbirth or after pelvic surgery. So these two questions will definitely give you idea. And nowadays, because these malignant fistula are also common, so we should have more, diagnostic algorithm. We can expand little bit, like whether it is after some malignancy or after radiotherapy or after some malignant surgery or presentation of malignancy also can be vesicovaginal fistula, because cervical cancer, carcinoma endometrium is increasing, and the therapeutic modalities are also increasing. So that also we should keep in our mind.
Okay, so I think you have described what are the types, but still, just to name, just to once repeat what are the types of fistula, like you started from ureteric, vesicovaginal,
So genitourinary fistula can be classified as we just describe as which organ involved. So it could be ureterovaginal fistula, it could be vesicovaginal fistula, urethrovaginal fistula, or also this can be anatomical, like we can say it's an anatomical classification. And some genitourinary fistula are like congenital ectopic ureter, with the ureter is opening in between labia majora and labia minora. So that can be congenital in origin. Otherwise, most of these fistula are acquired in origin, and many of them are obstetric, also like 50%, and half of them are iatrogenic. It is secondary to some procedures or some treatment modalities which is practiced by a healthcare professional, that results after the procedure, madam. So by etiology, it could be obstetric and iatrogenic, acquired and congenital. Then anatomical can be ureteric, vesicovaginal and urethrovaginal.
Very nice, very nicely explained. So can you describe global burden, because working at the global level? So please describe this global burden. What are the burden globally?
Yes, madam. Yeah, we grew up with the classic textbook reading of there are about 2 million women suffering with fistula, according to WHO estimates that we have been reading with this literature. But there are no actually research that substantiate WHO estimates of global burden. There are no studies around the world that actually estimates the burden of fistula. So it is assumed that for obstetric complication, for every woman who dies, 15 to 20 women survives. So fistula burden in the community, obstetric fistula, is directly related with the maternal mortality rate. So for every woman who dies, the 15 to 20 who survives develop one of the chronic morbidity, which is obstetric fistula. That is the global burden related with maternal mortality. So whichever country has higher maternal mortality rate, they have high burden of fistula, because fistula is a story of a woman who survives the death because of the obstructed labor. So regarding the complications after pelvic floor surgery or hysterectomy, it is believed that South Asia now has maximum number of iatrogenic fistula, and in fact India is a country which has maximum number of iatrogenic fistula. It is research conducted by Johns Hopkins University with the help of the local South Asia level professors. There's a very nice publication in Lancet which tells that there's a new belt of iatrogenic fistula which is in South Asia. So focusing India, Pakistan, Nepal, Bangladesh, because by virtue of the population, India has highest number of fistula. So throughout world, as maternal mortality is going down, obstetric fistula is going down, and iatrogenic fistula are coming up. So if you ask, in my experience, when I started my practice, 80% were obstetric fistula and 20% were iatrogenic fistula. But now when we see about 50 to 60% are iatrogenic and 40 to 50% are obstetric. So obstetrics are going down and iatrogenic are increasing, which is actually posing another challenge, madam.
I think because of better institutional care and institutional delivery, the incidence of obstetric fistula is going down. In
Yes,
our
ma'am. Yes.
Mamta and Asa, they all are working at the root level, and they advise the pregnant women to come to the hospital for regular checkups and even for birth. So this can be a good reason and for declining the obstetric fistula. So thank
Yes,
you.
madam. It is because of improved maternal care and
Yeah,
decreased maternal mortality. Obstetric fistula is going down, madam. But
yeah,
the increase in iatrogenic fistula is becoming more of a global challenge now.
yeah. So why this condition very important for gynecologists to learn? Because every of us has faced such type of fistula, not directly. Maybe the patient has come from outside, or sometimes even in our part also after prolonged or obstructed labor, she can develop. So why this can be very important for gynecologists to learn? Can you tell?
Yes, ma'am. It is very important because we have to train and orient our postgraduate resident as well as youngsters who are just starting their practice that obstetric fistula in the initial stage after obstructed labor can be preventable. So even if you are getting obstructed labor, if you continue catheter after up to 2 weeks after obstructed labor, obstetric fistula can be preventable. First, so we should be able to manage our labor room better. So that
Yeah.
is one thing. Second thing, even after occurrence of fistula, if you see them quickly, like early 4 to 6 weeks within the occurrence of fistula, if we put catheter, Foley catheter for 1 to 1.5 months, less than 2 centimeter fistula are likely to close spontaneously. So
Yes.
this is very, very important that we train our midwife and staff and our medical officers and nursing staff that fistula is preventable. So we have to do catheter treatment for early fistula. So if the patient is not treated in early period, when she become a chronic patient, most of us actually fail to identify that she has fistula. Many of us start telling her that you have UTI. So most of the women who comes to outpatient clinic and say that I have leaking. So we just say, okay, you leak urine. It could be either or just stress incontinence. So most of the cause of urge incontinence is secondary to UTI. So we start telling them you take urine REME, urine culture, and definitely there will some growth in culture because a patient with fistula will always be contaminated. So we give antibiotics. So I have seen many of us actually failing to diagnose that it is genitourinary fistula. So it is very, very important that it is possible for a woman to present in a variable way, and you always have fistula in your mind when you see a patient coming with urinary complaint after childbirth or hysterectomy. You have
Yeah.
to be very, very, we have to be
Yeah.
oriented. It's
Yeah. This
very,
should
very
be your.
important. Yeah, very important for gynecologists to have that orientation because the patient will first come to gynecologist, then only they will go to urologist or other. So we are always the first primary contact person. So it is very important that we are oriented. So it is important for gynecologists, madam.
Okay. Yeah, so we all should know and we should be aware if anyone comes with what is discharge for vaginum, we have to examine her and we have to know it can be a cause of fistula. So this is
Yes,
very
madam.
important for every
Exactly.
gynecologist to learn. Yeah. Describe the assessment of patient with genital fistula. So please describe how we will assess the patient.
So the assessment is actually, madam, the algorithm is very simple. When someone comes with leakage of urine, I describe in the beginning, you always ask them couple of more questions. You ask them, are you leaking all the time? If she says yes, it's very likely that she has fistula. If she says no, then you ask her whether you are leaking with cough or ors, those things you ask. If she says I'm leaking with ors or cough, then it is stress or urge incontinence. But if someone has stress and urge both, that can be very confusing with fistula because she leaks all the time. Someone has urge and stress, so you have to differentiate. So whenever you ask those questions and our answer is yes, you ask them that whether it started after childbirth or after pelvic surgery or some treatment of cancer. So if the answer is yes, then you take her for clinical examination. Clinical examination in a dorsal position, you put sim speculum and visualize her anterior vaginal wall. The most of the time fistula is visible. So if the visible fistula, you can just note it down. If the fistula is not visible, please palpate it. You will be able to palpate. So sometimes you need the guidance of your senior. So you remember that position of patient speculum is very, very important. Light. You should have good examination table with 2 stirrup. Ask the patient nicely to come down in the end of the table. And sometimes you have to do little bit head down and examine so that it exposes anterovaginal wall. Or sometimes you have to examine patient in the left lateral position, exaggerated left lateral position, which is also called Sims position, to see the anterovaginal wall. The vagina will be ballooned out and you will be able to see. If you are not able to see, you will be able to palpate. But either you are not able to see or you are not able to palpate, but you still see urine in vagina, then that patient is for the dye test. So you do methylene blue dye test, put a Foley catheter through urethra, inflate it, then instill the bladder with 60 ml of methylene blue dye. Okay, 60 ml of methylene blue. Ask your assistant to put the dye, and you visualize anterior vaginal wall. You will see dye coming out through some of the rent in the vagina. So that will also help you to identify whether there are one fistula or multiple fistula. Dye test. Yeah. So dye test positive, that is the hallmark of the fistula. So if the dye test is negative, sometimes the amount of dye also depends how much you have to put depending on the bladder capacity, but it's the standard practice to give 30 to 60 ml of methylene blue dye. So if you don't see dye in the vagina, but still you see urine in the vagina, they are likely to have the ureteric fistula. So ureteric fistula will warrant further test with CTI view or a cystoscopy. So that will be your next level of assessment. It's actually very easy to diagnose.
Yeah, thank you so much for explaining so easily, and it can be diagnosed, especially diet test, very important. Which type of fistula she is having and where is the rate. So that is very important. We can diagnose and we can even can say that whether there is one opening, one rent or more than one rent, that can also be seen. So very nicely explained. Now highlight the management of fistula. So how will we manage?
So management depends upon whether she is the fresh fistula or chronic one, madam. I have already explained. If you find your patient within 4 to 6 weeks of occurrence of fistula, she is fresh fistula. Yeah, after that, it's a chronic one, old fistula. So fresh fistula, always try catheter treatment. Put Foley catheter and give her some time. Explain if there are slough and necrotic tissue, you can do debridement and give her seize bath and ask her to wait, ask her to sleep in prone position. So she will come after a few days and say that she is actually emptying more in urobag than she is leaking. So she is progressively improving with her treatment, that she will leak less and she will void more in the urobag. So particularly fistula less than 2 centimeter, so they are very likely to heal with catheter. So give some time. So my message to all my friends are, because we are very worried. We do surgery, then patient comes with leaking. We are very, very scared. Oh my God, what has happened? So we tend to get apprehensive, refer patient to urologist, or and subject them surgery as early as possible. Don't do that. Explain the patient, take her confidence, and give her some time to heal, because she has just recovered from some surgery, and it's not good to have another surgery immediately. So the catheter treatment you must try if it is around a small to medium fistula.
Yeah.
But if it is very large one, or if it is a chronic fistula, it will not heal with the catheter. She will need surgery. Okay, madam. So the surgery depends upon what level of expertise you are. So it's always good to have a more expert surgeon operating on your patient. But there are several factors that actually influence the success of repair. But remember, for early fistula, try catheter treatment. For old fistula, surgical treatment.
Thank you so much. So I think you have already explained, but just to know, can a fistula heal on its own?
It does.
Yeah.
It does. I have experience of even a patient who had carcinoma cervix, underwent radical hysterectomy, and radiotherapy after that, and she developed fistula after radiotherapy. She healed with catheter treatment. So we always should respect patient own healing power.
Yes, yes.
Yeah.
So yeah, this is very important. Dwelling catheter can make women to get cure
Yes.
of the fistula, especially small fistula. So I think
Yes, ma'am.
this is very
Give 3 to
important
4
message.
weeks time, ma'am. Give 3 to 4 weeks time.
Yeah.
Convince your patient. Even if it doesn't close, it will make fistula smaller and more amenable for repair.
Okay. So yeah, I think this is very good message to all the viewers, all the gynecologists, that we should wait for at least 3 to 4 weeks before undergoing for any surgery, because at the time
Exactly.
also the bladder remains edematous now, so infected edematous. So I think surgery is not good at the time. So it's better
Yes, ma'am.
we should put the catheter and wait. If it gets cured, then all right. Otherwise, we will proceed for surgery.
Yeah,
So,
the tissue also get remodeling and they look better when you operate
yeah,
actually.
yeah. So I think you have well explained. So is there a risk of incontinence after fistula surgery? Someone has done surgery, maybe by some inexperienced gynecologist or neurologist. So can there be risk of incontinence, or what do you think?
It does, madam. After fistula surgery, patient can have residual incontinence, and if you see the global prevalence in the literature, is actually more than 30%. Patient after fistula repair will develop incontinence, post fistula incontinence. There are several reasons for that. Like if you are operating obstetric fistula, in obstetric fistula, because of the obstructed labor, there is always loss of anterior vaginal wall. That's mandatory. It's always there. So invariably there is loss of bladder capacity. So bladder will be small. So whenever bladder capacity is small, after repair, patient will have incontinence. So you have to assess bladder capacity during repair and plan accordingly your post-repair protocol. So it has a prognostic significance, bladder capacity during fistula surgery. So another reason of leaking is like you are operating near urethra, madam. If
Yes.
like if post hysterectomy
It's
fistula is
lateral.
also
Yeah.
very big, very big. It can because of the urethral length is involved or urethral closing mechanism is involved during your anterior vaginal wall dissection. Patient can have leaking in the post surgery period. Third cause of leaking is while operating VVF, you forgot that there is ureter at the margin. You could not splint the ureter properly. So you nicely close the fistula, diastasis is negative, but the ureters are somewhere in the margin. We could not do the splinting, and in post-op period, patient will have leaking even though diastasis was negative. So always look for the ureters when you are operating. So these three things. So particularly related with bladder capacity, we can always do a widening trial which can actually enlarge bladder capacity. So post fistula incontinence needs more of the expert treatment, and it also takes longer time. We have to have patience for that.
Yeah. So yeah, very nicely explained. So I think you have covered all the points. So how can a woman get prevention of incontinence after surgery? So we all know, you have also explained how can we prevent this obstetric fistula, but how to prevent genitourinary fistula in gynecological cases also. You have explained everything about obstetric fistula prevention, but can you explain how can we prevent this gynecological cases which occur after
Exactly,
laparoscopy?
it's very important.
Yeah.
Yes, madam. So all of us are doing cesarean section nowadays. All of us are doing repeat cesarean section. So
Yes.
most of the women, they are having cesarean delivery. Most of the public hospital are having cesarean section more than 50% everywhere. Same there in India also, no ma'am, as in Nepal.
Yes.
We have very high.
Same thing.
Exactly,
Yeah.
ma'am. So the best way is to prevent more cesarean section. We have to prevent more cesarean section. The first delivery, we should encourage to have a vaginal delivery. So if we are doing cesarean in the first pregnancy, then it's likely that the second will be CS only. So all of us are operating repeat CS. Invariably, the bladder, you have to be careful that you have to look bladder nicely and separate it. Particularly separation of the bladder, most of us attempt separating it from the center. So I can show in AICOG how to separate bladder. in a video, you always start from the lateral window, madam, because the lateral window are easy. So from lateral to center, you come and nicely separate the bladder, ma'am. We have to be careful of the anatomy. In fact, there's a very nice article from Africa which tells that most common cause of ureteric fistula in Africa is secondary to cesarean section, madam. They have
common for hysterectomy. Oh, that is not in our part. In our part, is more common after hysterectomy.
Exactly, ma'am. So no, my emphasis is in cesarean section also we can easily tie ureter.
Yeah.
So yeah, the ureters are very close during pregnancy because of the dilatation and the push from the sigmoid colon. The left sided are more likely to damage than right side. So nicely separate urinary bladder and lateralize the parametrium and deliver the baby is very, very important during cesarean section. Whenever you have doubt, you please call your senior.
Yes.
Do a dye test or cystoscopy at the end if you have doubt, because intraoperative detection is much better than letting patients suffer in postoperative period. It's very important. For in hysterectomy and other pelvic surgery, I think you assess the difficulty before surgery. If you are operating a malignancy patient, if you are operating a endometriosis, so you prepare. You can even do a preoperative stenting of the ureter.
Tuberculosis and PID, they can have
exactly. Yes, ma'am. So pelvic anatomy is completely distorted in these cases. So you have to take,
especially
ma'am. Multiple myoma, cervical myoma, all those cases. So you have to be, you anticipate it before surgery and do some preoperative preparation. If you want to see the course of ureter, it's always good to do a preoperative IVU before you plan surgery, ma'am. So that you know how the ureters are going. And intraoperative also, you have good communication with your urologist team, and you should be careful with your every steps. Try to normalize the anatomy and look for urinary bladder and ureter. So there's a very famous article from Peter Dreyer from Australia, which tells that if you are aware intraoperatively, it is very unlikely that you get a litigation after surgery, even though if you miss some intraoperative urinary tract injury. So you have to document all the steps. We have to tell our youngster to document all the steps what you have taken to prevent urinary tract injury, madam. It's very important. Whenever there is doubt, please do the testing. Never hesitate. You will never be inferior doing a cystoscopy after surgery. Please put a scope and see that both ureters are draining. If you don't have cystoscope, put a hysteroscope. It doesn't matter. But visualize urinary bladder and see the ureter.
Ureteric orifice. I think so. Every gynecologist should be trained not only in the hysteroscopy but in cystoscopy also. So
we have to train our youngsters.
Yeah, we are having a workshop in Jabalpur next month, where I and Dr. Amita both are going, and they are having hysteroscopy cystoscopy workshop. So I think
let everyone hold the operative sheath and insert it inside.
It's better that everyone should. And I think by doing cystoscopy, many questions will be answered. So if there is any ureteric orifice is closed or urine not coming from any ureteric orifice, simultaneously we can call either neurosurgeon, we can do ureteric stenting. So that will help.
Ma'am. Then and there you can manage, madam. It's very, very important.
So I think whenever there is doubt, when there is any such type of anticipated complication, we should be ready for cystoscopy, and that will prevent many of such type in future. Okay, thank you so much. So
you're welcome.
Do women leak even after the treatment? The incontinence you have explained, but still women leak after treatment of the fistula. Do you think?
Some of them do leak even after in long-term basis, madam. That is because they develop de novo incontinence after surgery, which should be managed medically. Patient should be counseled beforehand. Some of the patients, they will, it can be managed medically.
Okay.
So one thing I want to emphasize here, madam, if patient is having stress leakage after fistula surgery, particularly if you are operating fistula near your bladder neck, and if she develops leaking after that, never put this alloplastic slings, never put polypropylene tape.
Okay.
The best treatment for them is the autologous sling.
Autofascial slings.
Yes, ma'am. Fascial sling. Yes.
Yeah,
Don't put polypropion tape.
that work is being done by G.V. Sarma sir. He has done lots of
Yes,
work.
exactly. Yeah, pioneer. His work is pioneer, man.
So yeah, this point should be kept in mind that if the woman has recurrence, we should use autofossil cells. So what are the psychological impacts of dealing with this type of fistula leakage or incontinence? So what are the impacts of the patient? Because they are really same. They don't go to social outings, or they don't even go to worship room many times, and they are very depressed. What do you think? What are the psychological impacts? We are dealing so many cases. Yeah.
Exactly, ma'am. Psychological and social impact are enormous, man. But if you see obstetric fistula, most of the obstructed labor causing fistula, they will have perinatal death. So the outcome of perinatal death also is stillbirth. So it's very bad for women to develop fistula, then have a dead child. And as you say, she will be secluded and she will not be able to move in the society. And gynecological surgery, patient come to you for gynecology treatment, they get hysterectomy, then leaking of urine is something they have never imagined. No, I'll get this complication, and then we also fail to tell them that you might develop this thing. We are also hesitant and afraid what the patient might go to another doctor if I tell all the complication to her. But depending on the complexity of the cases, it's always important to tell your patient that we are likely to develop these things, but whatever complication
can be complications.
Can be managed. Yeah, can be managed, but you should be mentally prepared. Like last couple of months back, I operated a patient who had cervical myoma. So she was getting surgery treatment for urgency everywhere. So no one told her that she has cervical myoma actually, which is pressing behind the bladder and causing urgency. She came to me. I said, after clinical examination, I said there's a myoma in between bladder and uterus, so it is causing urgency. It needs to be removed. Then she was not convinced. Previous to cesarean section. So then she went to all the doctors. Then finally she again came back to me. I said, see, we need to operate on you, but there is very significant risk of bladder injury because of 2 previous years and myoma. Yeah. Then she slowly got convinced. Then we operated, and in fact she got bladder injury because we could not get myoma without opening bladder. It was not possible. Yeah.
I think same thing has happened to me also. I think 3 months, 4 months back.
Yeah.
So it happens. So yeah, that should be mentioned, I think, when explaining the types of surgery and whatever complications she can have. So this will prevent us from litigations.
Yeah, exactly. And this also prevent more psychological damage because patient will be mentally prepared beforehand. So I might get this. So it's possible, but that is amenable for treatment. So after that, when a patient leaks urine, usually which is after benign gynecological surgery, patient gets very apprehensive, and same time doctors also get apprehensive because we are also not prepared for handling that kind of complication. We should just reassure the patient, don't worry, things will be okay, and it is amenable for repair, and long-term outcome are very good. So I think it's very, very important that we do psychological counseling, and in fact the mental health treatment is also needed many times. If you see literature around the world, there are many literature correlating with the mental health status of fistula patient, and separate counseling might be needed also.
Psychological counseling, I think it's very important. So most of the topics have been covered. What is the prognosis for fistula and incontinence repair? So you have already explained, I think, more or less the prognosis is good, but still you have mentioned that in 27% or 30% cases there can be recurrence, right? So
yeah, ma'am, they can have post fistula incontinence, but most of the fistula, about 85 to 90% fistula are amenable for repair. Most of them are repaired vaginally. So that one thing I want to emphasize is management. Whenever possible, we should try to repair vaginally. We should not go abdominal, laparoscopic or robotic approach, because as gynecologists we should train and we should spread the vaginal surgery techniques to all our youngsters. We should teach them. So it's always good to have a vaginal repair of fistula, and most of them can be repaired vaginally. So the outcome is very good in
very
that.
good message that vaginally it can be repaired. So it will can help us gynecologists also that we can repair. So this is very
Yeah,
important.
it is our domain, no? Our domain. We have to do vaginal surgery, and in fact, I am only teaching vaginal surgery techniques. I hardly do abdominal repair of fistula unless it is a ureteric one, madam. Yes, madam. Most of the patients who develop incontinence after fistula
I think
repair
you have
are
explained how can diet and hygienic practices.
okay, madam. So for fistula patient, it is very important that they drink lot of water. We have to encourage them to drink lot of water,
Yes.
because they think that by drinking more water they will leak, so they will drink less water.
Okay.
But if they drink less water, their chance of stone formation in the bladder.
Yes, yes.
So to prevent that, they should drink a lot. Even though they leak, they should drink a lot, because that will maintain their flow of the urinary tract, and that will also prevent ascending infection, madam.
Thank you so much. And other things like vitamin C or these things can help them. Or some antibiotic she should take for that to prevent any sort of other infection, because continuous leakage can have damage to that part also, na vulva and vagina. So should we advise some other thing, not only water but other things like many people say vitamin C should be given, some article has shown, and by giving some antibiotic, no, it's not necessary.
Madam,
Protein
antibiotic
diet.
actually does not help, because once she starts leaking, vagina pH will be changed and it will be converted to alkaline. Otherwise, vagina pH is acidic. When there is alkaline pH, there will invariably E. coli coming from the gut. So whatever dose of antibiotic you give, E. coli will be there. The only way to flush E. coli is to drink lot of water, which maintains continuous flow of urine. I do not prescribe any antibiotic unless she is catheterized, madam. If she is catheterized, then I'll give her prophylactic dose of antibiotic. Because everyday risk of UTI with catheter is about 4%.
Okay, so what antibiotic you prefer?
Yeah, I usually give nitrofurantoin, prophylactic dose.
100
100 milligram HS bedtime. That is the prophylactic dose.
Okay. What are the hygienic practices that you recommend for the women who are suffering from such type of fistula? So she should maintain proper hygiene, or should she should take any wash or anything?
Yeah, seize bath, madam. Seize bath with lukewarm water with pinch of salt.
Okay, gypsum.
That's the only thing I advise for patient, because common salt has healing property. So so lukewarm water with salt is what I advise to them. No wash or nothing else. No commercial preparation.
Okay, only seize bath with gypsum.
Yes, madam. Yes.
Okay, so I think you are working for making Nepal fistula free. So I think we should join hands and we should try to make our country also fistula free, because many women are suffering both from sitting and.
We should
so I
join hands
think
together.
we need your help. So in AICG 2026, we will have brought this discussion so that we can join Amita, JV Sarma sir, every gynecologist will be there. So we can work together to make our women also fistula free. And this should
Looking
be,
forward for it.
yeah, this should be done at the root level, not only in the metros, but in the smaller villages also, because most of the women are from small villages and don't have proper facilities. Even when they develop fistula, they shy, they don't come to doctors many times. So this is, so I think
education part, we should say, we should combine these chapters in undergraduate curriculum as well, ma'am.
Yes, it's very important. Both undergraduate, postgraduate should learn these residents. Yes. Okay, thank you so much. So
thank you for the opportunity, madam.
Yeah, thank you, Sunita madam, Dr. Mohan, for answering such in a broad way. Every question has been answered very well. So the doctors and clinicians who are listening, they can be benefited with all these answers, and all dots will be clear. And thank you, support team, Mr. Pradeep, Rohitji, Kripa, for giving us the platform for conducting this podcast. Thank you so much. So should we
Thank
close
you,
now?
Sunita ma'am and
Okay.
Kavita ma'am,
Thank
and
you,
whole
Dr.
team.
Kumar,
I'm
and happy
honored.
Deepavali. Okay.
Thank you, madam.
Thank
Same to
you.
you, ma'am.
Yeah. Thank you so much.